Tonight, we are joined by Dr. Louis Saffran. Dr. Louis Saffran received his medical doctorate from the University of Maryland and did his residency and fellowship at North Shore University Hospital Manhasset, which is now a part of the Northwell Health System. He is board certified in pulmonary critical care and sleep medicine. He serves as the assistant professor of the Icahn School of Medicine at Mount Sinai, and he is the director of Mount Sinai South Nassau Center of Sleep Wellness. Thank you so much for joining us. Let's get started.
Okay, thank you very much. So today I was going to concentrate mainly on sleep apnea and the different options for treatment. I'm going to go through some, I took a slide deck that's from the Annals of Internal Medicine. I made some adjustments to it to update it because it's from 2014. But I'll start now and we'll go through, and if you guys have questions, I guess at the end we could go over them. All right, so sleep apnea is a common problem. A lot of times I have patients, spouses that are bringing in their loved ones complaining that it's disrupting their sleep because they're very loud at nighttime, snoring, and so forth. A lot of the loved ones feel that they may be waking up, but they're not necessarily having any significant issues in some cases, and in other cases they're very tired during the day falling asleep. So something to think about: you could live 3 weeks without food, 3 days without water, but only about 3 minutes without oxygen. And apnea is a serious condition, and if it's happening multiple times an hour at nighttime, it puts a significant strain on their heart. There's a lot of things going on at night, not just that is controlling your sleep. Your core body temperature fluctuates as you're falling asleep. Your heart rate fluctuates different stages of sleep. Your plasma cortisol level is starting up and then dropping through the night. So there's a lot of different factors that affect your sleep at nighttime. There's the homeostatic drive and the circadian system. The circadian system is basically how your body reacts to light and melatonin and some other hormones in your body that tells it that it's time to go to sleep and to fall asleep. And there's a homeostatic drive. If you're not getting enough sleep, your body will also demand sleep. So there's a lot of different things that drive your sleep at nighttime. So sleep apnea is basically when you're not breathing. Obstructive means that you have a blockage that's causing that problem. A single event for an obstructive sleep apnea could usually last about 10 seconds up to 2 minutes. You could have hundreds of them per night or even per hour. Who should be screened? Basically, any person that's dissatisfied with their sleep should have some screening done. If they're complaining about daytime sleepiness, if they have risk factors such as obesity, family history of obstructive sleep apnea, we're all built like our relatives. So if you have a father or sibling that has sleep apnea, there's a good chance you may have it. Retrogonanthia is when the chin is set back. That obviously worsens sleep apnea because that causes more crowding in the back of the throat. Hypertensive issues or control could be a problem. If they have cardiac issues such as atrial fibrillation or stroke, it could be related to sleep apnea and could be made worse if the sleep apnea is not fully controlled. Diabetes. Patients who have occupations that involve driving and are putting other people's lives at risk, such as bus drivers. These are patients that you should really screen and make sure they don't have sleep apnea. There's questionnaires that we use in the primary care setting. There's the Berlin questionnaire, which asks about snoring and severity, etc. In the pre-surgical setting, we have the Stop Bang screening tool that we use. These are very crude tools. They pick up a big majority of the patients. They're not going to pick up everyone, but they're pretty useful to use in those settings. Sleep apnea is not going away because obviously obesity is a big problem. There's a lot of patients are not watching their diet and gaining weight, not exercising as much as they should be. So one of the things we try to do to improve sleep apnea in patients that are overweight, because not everyone that's overweight, not everyone that has sleep apnea is overweight, but a majority are, is obviously attempt to have them lose weight. Reducing their BMI helps because it reduces the tissue in their throats and opens up the airway. All right, so bottom line is we should question our patients about daytime sleepiness, take a good history using validated questionnaires, and then we should screen them for things like obesity, cardiac disease, and if they have history of drowsy driving, these are all things that should raise a red flag. Things we question the patients on, we'll ask them if they're being told that at nighttime they may stop breathing. Their loved ones may shake them because they don't hear them breathing at night when they were snoring prior to that. If they have loud, bothersome snoring, if they're gasping at night, if they're tired during the day, drowsy driving, if they're having frequent urination at nighttime. Typically every 2 hours, patients are woken up during REM sleep to urinate, because during REM sleep, your muscles are paralyzed because that you don't want to act out your dreams, and that includes your muscles in your throats. So if you're having a closed airway because your muscles are relaxed as you're getting into deeper sleep, and then they become paralyzed during REM sleep, there's no airflow, and slowly your blood oxygen level drifts down, and then your brain has to wake you up in order for you to get oxygen, at which point most people get up and they go urinate. And this happens in cycles of 2 hours every night. So every 2 hours they get woken up, go urinate, and then they think it's because they have a large prostate or drink a lot of fluid or they have a weak bladder, but they don't urinate every 2 hours during the day. And when we diagnose them with sleep apnea and treat it, they stop waking up at nighttime. So obviously it's not because they had to urinate, it's more likely because they had sleep apnea. You want to, in the absence of symptoms, and you want to evaluate patients that are morbidly obese, patients that are going for bariatric surgery, because you want to alert anesthesia to beware of these patients and monitor them more closely to see if they're having apneic events, because they're going to be recovering from anesthesia and they're more likely to have more problems postoperatively. If they have refractory hypertension, these are patients that you want to screen for sleep apnea. Other conditions obviously could affect your sleep. So not every patient that comes into you and is tired necessarily has sleep apnea. And here's a list of other related sleep conditions or medical conditions that could cause problems to make you sleepy during the day. Physical exam findings. So I typically will measure the patient's neck. There's a higher risk for patients, females that have a neck greater than 16 inches or men greater than 17 inches. Mallampati score, I'll go over in a few seconds, but it's basically the airway opening, how much of the airway is occluded when you look at the back of the throat. Macroglossia or tonsillar hypertrophy, you want to look at the back of the throat and see what's going on back there. If they have enlarged or elongated uvula, high arch palates, nasal obstruction, and retrogonanthia. So the Mallampati score, here's a crude diagram showing what it is. There's class 1 through 4, and it's basically how much of the posterior pharynx you could see when you look at the back of their throats. And here's a little more live pictures of it. And if you see someone's a class 4, they're obviously higher risk for having sleep apnea. And here again is a normal airway on the left side when the patient is awake, but as he falls asleep, you can see how the tissue flops down in the back of the throat and is obstructing his airway. So a lot of patients will think, well, maybe I should just trim all the tissue, including the uvula at the back of the throat, and that's not necessarily going to solve all the patient's problems. Works about 50% of the time. What type of sleep studies do you do? Well, typically we used to have the standard in-lab sleep study to diagnose sleep apnea. Nowadays with commercial insurances, we're being pushed more to do the home studies because they are less expensive, obviously, and most of the time they could give you the information you need. So if patients don't have a lot of comorbid conditions such as cardiac disease and other things like that that you need to look into, or if you're not concerned about things like restless legs, doing a home study is usually adequate. A split night study is typically if you have a patient that has a high suspicion to have sleep apnea, you may want to split the study, so you do half the night to make the diagnosis of sleep apnea. The other half of the night would be for treatment, in which you put a CPAP mask on them and treat them. And sometimes this is done without being ordered if the patient is having arrhythmias while he's sleeping because of the apnea and is having severe apneic events. So this is what a patient typically looks like when he's all wired up in a sleep lab. He's got leads on his scalp to monitor his brain waves. He's got leads around his eyes so we can see his eye movements when he's going into REM sleep. He's got chin lead to measure his muscle tone, a lead on his leg to monitor his kicking. He's got electrodes on his chest to monitor his heart, and strap on his chest and abdomen to monitor his breathing pattern, and a pulse ox on his finger to monitor his oxygen level. So the patient, we get a lot of information, and the whole thing's also being videotaped. So if the patient is having any abnormal movements at nighttime, we could take a look back at the video. This is a typical polysomnogram tracing on the top of the diagram here. You can see are the leads for the frontal lead, central lead, occipital lead. These are the brain waves that you're seeing on the top. The REOG and the LEOG are the eye movements. This is the chin as the EMG that we're monitoring to see their muscle tone. You have leg leads to monitor also muscle tone, and also kicking to see if they're restless legs. You have a mic so we could tell if they're snoring. The thermistor is really telling their breathing patterns through the nose, how they're breathing. You have a chest lead, abdominal lead, an EKG to monitor their heart, a pulse ox, and you can tell their body position. So a polysomnogram is a very involved test. It has to be scored in stages by the sleep specialist. We usually break it down into reading the EKG, the leg movements, and then the brain waves to see the stage of the sleep, and then respiratory events. So you go through the whole study for the whole night in multiple stages, and it takes a fair amount of time, but with time and experience, you get faster at doing it. The role of the home sleep study, again, if it's an uncomplicated patient with no other comorbid issues, and you have a high suspicion they have sleep apnea, it's much lower cost. Most insurances prefer it, and you could do it pretty easily. And a lot of patients like doing it because they don't have to go to a sleep lab for the study. If the test is negative and you have a high suspicion, you may need to do an in-lab study or repeat the test, because home sleep studies, again, are not monitoring the brain waves, so we don't actually know the stages of sleep the patient is going through, but we don't know the stages of sleep that the patient is going through. So if the patient is awake during the home sleep study and they have a certain amount of events, and say they're awake for 5 out of the 10 hours that they're wearing the sleep equipment, then it's really cutting in half what their amount of events are per hour, because we take the 10 hours, for example, and divide all the events over those 10 hours. So if they had 10 events an hour over those 10 hours, it's really 20 events if they only slept for 5 of them. So it could underestimate sleep apnea. So this is what a home sleep patient looks like. This is one type of sleep equipment. It's a ResMed. There's a monitoring device under the nose that is measuring his snoring and his breathing pattern. He's got a strap on his chest to monitor his chest rise and lower, so you can tell when he's breathing or struggling to breathe. And he's got a pulse ox on. But again, you can see we're not monitoring his brain waves. This is purely to monitor his respiratory status while he sleeps. And this is what you look, as opposed to that big overnight polysomnography. You get this type of tracing. And here you can see this is the rest when he's breathing, and when he's not breathing is the purple over here. You can see when he's trying to breathe, which is the effort belts, and you can see the chest trying to rise and lower when he's having the apneic events. And then over here, the purple on the bottom, the dark purple on the bottom is really when his oxygen levels are dropping. So this is what we see with a typical home sleep study. And it's hard to, if they're awake, you're not going to see any of this, and you may think it's a normal study if the patient, for example, stayed awake the whole night. This is what the report would look like, and basically it would tell us how many events per hour. And here you see it's circled at 56 events an hour. So this patient has severe sleep apnea. This is just one example. All right, so apnea-hypopnea index is really how many events an hour the patient is having. So 0 to 5 events an hour is considered normal. Most patients have some sleep apnea. Mild sleep apnea is 5 to 15 events an hour, moderate is 15 to 30, and severe is greater than 30. So apnea, again, is a cessation of breathing for greater than 10 seconds. Hypopnea is when there's a flow reduction and a 3 or 4% desaturation. The 3 or 4 comes in if it's commercial patients, they require only 3%. Medicare patients require 4% desaturation, so it's really technicality, but if they have 4% desaturation and some reduction in flow for greater than 10 seconds, then that's considered a hypopnea. Other things we measure is the total sleep time, obviously the quality of the sleep, we could tell. And we're measuring the EEG, so you could pick up some epileptic events. You could pick up things like restless legs, arrhythmias during the sleep study. And all of these things could explain why the patient is tired during the day, and it may not necessarily be sleep apnea, or it may be contributing to it. So when to send a patient to a sleep specialist, because not everyone that has sleep apnea has to be seen by a sleep specialist, although most people end up coming to us just because it becomes a little complicated to treat these patients, and you don't want them to get frustrated if you're not familiar with the equipment to use for treatment. So if they're obviously complex patients with, very difficult to treat sleep apnea, if they have other suspected sleep disorders, such as narcolepsy, for example, or restless legs, things like that, you may want them to come to a sleep specialist. Or if they have parasomnias, if you want to ensure that they're getting the right test, because obviously someone with narcolepsy, they don't just need a regular sleep study, they need a multiple sleep latency test after the sleep study, which is a daytime study, and where they sit in a dark room and see if they fall asleep and go into REM sleep, which isn't really the purpose of my talk today. If you're going to diagnose someone with sleep apnea, you should be prepared to treat them. Or if you're not prepared to treat them, have some sleep specialists around that's willing to treat them, because you don't want to just give them a diagnosis, throw them a machine and say good luck, because if they have tough time with the machine, you have to be prepared to change the mask or change the pressure or work with them to try and figure out what's going on with that machine and why the patient isn't tolerating it. Because otherwise, if you get a frustrated patient who has a bad experience being treated for sleep apnea, they may not end up being treated, and it could affect their health going in the future. All right, so prior to an evaluation, patients should be explained what they're going to expect. You want to give them a description of what a sleep study is. You want to talk to them about once they are diagnosed with sleep apnea, depending on how severe it is. When they come back to go over their study with you, you want to explain the different options of treatment for the patients, depending on how severe their sleep apnea is. And obviously, you want to explain to them what sleep apnea is and why they're going for the study. All right, so again, this is just to summarize, what you're looking for if they have signs of sleep apnea, if they're going for bariatric surgery, if they have poorly controlled hypertension. The gold standard is in-lab sleep study, but there are home sleep studies available. If they have mild to moderate sleep apnea after you do the testing, you can counsel them on weight loss. If they're having issues with nasal congestion, you could try treating that and see if that helps improve their sleep apnea. Things like alcohol and sedatives will make sleep apnea worse. And a lot of patients will tell you that if they drink alcohol, that they really snore and they wake up a lot at nighttime, because what that is doing is blocking their body's ability to wake up when they're having apneic events. And then they end up really having severe hypoxia and gasping in the middle of the night and waking up. Other trials besides, you want to offer them a trial of CPAP, even if they have mild or moderate sleep apnea. If they're very sleepy during the day and they're having a lot of symptoms at night, and if they're having near-miss accidents, even though it's mild or moderate sleep apnea, you would want to treat someone like that rather than have them just go to weight loss, because you do not want them to hurt themselves or other people. Patients who are asymptomatic and have mild to moderate sleep apnea, and say they're brought in just because of snoring by their spouses, I don't necessarily fight with them to treat, unless they're very tired during the day or they're waking up a lot at nighttime. If it's just pure snoring, I won't necessarily send them and put them through a treatment with CPAP or dental appliances, etc., unless they're wanting to do it in order to make their marriage a little better because the snoring is disrupting their spouses. All right, so weight loss helps reduce the severity, and obviously recommending a diet and exercise is very important. If that fails and they're very overweight, you could recommend bariatric procedures to help treat them. If patients you find are having worse sleep apnea in different positions, you may want to recommend they sleep on their side rather than their back or even on their belly. And there are things on the market such as wedges that you could purchase so that they don't lie on their back. Some patients have even sewn tennis balls into t-shirts and slept with them, so it's uncomfortable for them to lie on their back. But positional training is one of the things you could do if it's just positional when they have their sleep apnea. That's not as common as we think. So the gold standard for treatment is CPAP. There's different types of masks. This guy's wearing a nasal mask, nasal pillow mask. And then the other treatments are surgical treatments, weight loss, oral appliances, and more recently the Inspire device, which we'll talk a little bit about. CPAP, the way it works is it blows air at a high pressure through the nose or the nose and the mouth, depending on what type of mask they're using. By doing that, it stents the airway so that it doesn't collapse when the patient is getting into deeper sleep. And if they're able to get into deep sleep without having obstruction, then that solves the problem and the patient's able to stay asleep all night or most of the night and feel refreshed in the morning. So you really have treated them. Prescriptions, obviously you need to put the pressure setting, the mask size and type. Usually they have a heated humidifier. Some patients decide to turn it off if they don't like dealing with it. And obviously you're ordering filters for the machines. Traditionally, the in-lab titration is done for these patients so you can get an idea of what pressure they're going to need when they're sleeping. Alternatively, you could order an auto titrate CPAP machine, which works very well, and it starts at a low pressure and slowly increases as the patient is getting into deeper sleep. And the machines are very smart and could actually give you a range of what pressure they need. And when they come to your office, I usually leave them on an auto titrate setting, but at some point, they may find it uncomfortable for the pressure to be changing, and sometimes I have to set it to a fixed pressure, but I have a good idea based on the range of pressures they're getting when they're using the machine, because I'm able to get a printout from the machines when they come every visit to my office. So you want to educate the patients about their equipment, how to care for it, how to clean it. You don't want patients to get sinus infections because they're not cleaning their reservoirs out. Things like using a teaspoon of white vinegar is very helpful to disinfect the reservoirs. You can use simple things like dish soap. You don't have to use anything fancy. You obviously don't want to use bleaches or hand soaps, anything that has alcohol or bleach in it, because getting that blown up your nose isn't very good. And you want to make sure to emphasize the importance of keeping the machine clean, because otherwise they're going to get recurrent sinus infections and end up having to see the ENT and get that treated. All right, so CMS requires that we monitor patients and make sure they're adherent to using their CPAP machine, because obviously you don't want to give them a machine and then they end up throwing it in the closet and not using it. And what they do is the machines are typically rented for a year and then the patient owns it. But if after 3 months they're not using it more than 4 hours a night, 70% of the time, they're going to say, give back the machine. We don't want to pay for it anymore. And all the commercial insurances are following these guidelines. So it's very important to emphasize to the patients, even if they go away on vacation, they should bring the machine with them, especially the first few months that they get the machine. Because if they get sick and decide not to use the machine or go away and don't use the machine and they're not hitting that goal of 4 hours a night, 70% of the time, then within 3 months, either they're going to get a big bill from the DME company because the insurance won't pay for it, or they're going to have to give it back and you're going to have to start all over again. So it's very important to explain this to the patient. There is a linear relationship between CPAP use and improvement, obviously of sleepiness, quality of life, and blood pressure control. This is an old compliance report. The top graph here will show you someone that's very compliant. You could see that this is the 5-hour line. Usually it's a 4-hour line, but you could see this patient is using his machine more than 5 hours a night. The black bars over here are when he's using it less than 5 hours a night. So this patient's very compliant. This patient down here, you could see, is not very compliant. He's using it only 1 to 2 hours, and you can see those by all the black lines, but none of the nights is he using it more than 4 hours. And he could see there's a lot of empty spots in between the black lines. Those are nights he's not using it at all. So this patient is someone you're going to have to work really hard with to get used to his machine. All right, so what factors can optimize? So typically this says to have the patient come back 1 to 2 weeks. I usually give the patient 4 weeks to come back and to work with the machine. If they have obviously initial problems right away, they give me a call and I'll try to guide them beforehand. I usually want to get a 1 month printout because this one, it qualifies them. If they already are doing well with the machine, I just send that to the DME company and they're done, and they'll be able to keep the machine for the rest of the year without any worries. You want to, if they have their bed partner with them, you want them to be supportive. You want to explain to them what's going on with the machine, because sometimes if the mask is leaking and blowing into the partner's face, the partners get frustrated also. You want to help them setting their goal to using the machine. Sometimes they, you have to explain to them, if they're having a tough time, that maybe to put it on when they're watching TV at night, just to get used to the feeling of wearing the mask. You want to troubleshoot with them. If the pressures are too strong, you could actually adjust them so that they don't hit such high pressures. And you could do that remotely, actually. If they have nasal congestion, they should be given nasal sprays. And if the pressures are too strong, like I said, we could lower them and adjust them if they're on an auto titrate machine. Sometimes we may need to even give them hypnotics to help them fall asleep or to get used to using the machine. And a lot of times we end up weaning them off of it as they get used to the machine and they feel that they're sleeping well with the machine. The hypnotics I'm not a big fan of. I use them very rarely, but sometimes I do have to use it in some patients. And obviously no mask is superior than another. It's like going to a shoe store. You want to try it on and see how it fits and kind of wear it while you're sleeping. There's all different types of masks. There's nasal masks, there's full face mask, and there's nasal pillow masks. And there's different companies that make each of them. So the full face mask covers the nose and the mouth. And it's typically for patients who can't keep their mouth closed when they're sleeping. And there's the nasal mask that just goes over the nose or under the nose, but covers the nostrils. This is better for patients who have some claustrophobia and don't want to wear a full face mask. And then there's the nasal pillow mask that goes right in the nose. Again, it works for the claustrophobia. And it also, the nasal mask, the nasal pillow mask, there's no pressing on the bridge of the nose, because a lot of patients, they tie their mask really tight and then they end up getting breakdown on the bridge of the nose. And that becomes a problem. Again, these are old masks. This is not the newer masks. I should try and update this, but this is a full face mask. It looks like a pilot's mask. This is a nasal pillow mask. The newer nasal pillow masks don't have the strap going up between the eyes here. They usually have a strap, tube hanging down in front, or a tube attached on top. But anyway, so this is a nasal pillow mask. So some of the patients, they come in saying, it feels like I'm sticking my head out of a car window, and you need to coach them through it. Like I said, you tell them to wear it when they're watching TV to try to get used to it. The alternative to a CPAP in patients who have mild or moderate sleep apnea is a dental appliance. And the way the dental appliance works is it pulls the lower jaw forward. Let me So here's a picture of a dental appliance, and it gets adjusted so it pulls the lower jaw forward. By doing that, it stiffens up the back of the throat and pulls opens up the back of the airway. Let me just go back here. So it decreases the collapsibility of the upper airway. It does require that the patient has teeth, and it may exacerbate things like TMJ, but it does work well for mild to moderate sleep apnea. I don't usually recommend it for severe sleep apnea because I don't find that it works very well for them. Uvular phalangeoplasty, it works in about 50% of the patients. It's a pretty significant surgery. Tonsillectomy and nasal septoplasty and other ENT surgeries work well. Those are more recommended for the pediatric population and the adult population. I have some patients I've sent for it and they've done well, but it typically it's not something I would send the adult population for treatment. Maxillomandibular advancement is a big surgery and it works very well, but it's not a good surgery to recover from. But it does work well. And obviously tracheostomy bypasses the whole upper airway. And I've used that maybe in 2 patients in my whole career who had severe sleep apnea where they were having cardiac events and cardiac arrests even from the sleep apnea, and they were not compliant with CPAP, so they ended up needing a tracheostomy in order to survive. This is an example of uvular phalangeoplasty, and you see once in a while these patients, they come in and they open up the back of their mouth, and you can see right away what they had done there. And it works so well to treat patients that are snoring, but it doesn't necessarily get rid of the problem because further down they have the obstruction. So even though they got rid of that uvula, they're still having obstruction in the posterior pharynx further down. So the Inspire device is a newer treatment. It's been out for 5 to almost 10 years. More in the last 5 years, it's become very popular. There's been a lot of commercials on it. Again, this is an older slide, but basically it's a hypoglossal nerve stimulator. There's a wire that goes around the hypoglossal nerve, which is in the back of the throat here. And this is a battery, and then there's a wire that's between the rib. And basically, this is turned on when the patient goes to sleep. And when the device senses the patient is taking a breath, it sends a shock to the hypoglossal nerve, which opens up the back of the throat and pulls the tongue forward. So this treatment works well for sleep apnea. And it is a surgical procedure. It's a same-day procedure. They go in, they get the device implanted. They wait a month to let everything heal, and then they come into the office to get the device programmed, and then it's slowly adjusted over about 6 months. So again, this is the stimulator lead is in the back of the throat. The generator, the battery is placed in the chest, and there's a wire between the ribs. All right, so sleep apnea monitoring, you want to make sure at every visit the patient's using their device, their CPAP machine. If they're having an Inspire, we also make sure that they're using it. It's very easy to monitor compliance with the Inspire device. We can interrogate it when they come to see us. You want to monitor for side effects from the CPAP machine, such as dry mouth. They could do things like adjusting the humidification. We could adjust the pressure. You want to make sure that they're working on weight loss, and that could be with diet and exercise. It could be even with surgery. You want to make sure that they're not drowsy when they're driving, because some patients, even though we treat them, either they're not getting enough hours sleep or they are getting enough hours sleep and they are being treated appropriately with CPAP, but they're still having drowsy driving. These are patients you may need to put on stimulants because you don't want them to have car accidents. If they are relapsing, you want to make sure they're adherent, and we could do that now by just interrogating their machine. There's a lot of patients, especially if they're working for the bus company, may not be convinced they need to be treated for sleep apnea, and then next thing they know, they have an accident. So you want to make sure that they're adherent to their treatment, and we do this by having them follow up with us. If there's problems with their machine. Sometimes it's not functioning problem, properly, then we have to send the machine for repair, etc. And you want to make sure the pressures are adequate, because sometimes the patients are set for a fixed pressure, then they gain weight, they may need higher pressures. So even though they're using the machine, they may not going to be getting an adequate amount of pressure. So you want to make sure that they're getting the proper treatment. And obviously you want to make sure there's not other reasons that they're tired. All right, so when patients are admitted to the hospital, we always instruct them to bring their CPAP machine or their mandibular device, especially post-operatively, to be used, because if they're getting any sedation, it's going to worsen their sleep apnea. And when they're recovering in the recovery room, sometimes they're having very severe apneic events, and this will help prevent everyone from having a heart attack, including the patients, post-operatively. So you want them to bring their machine that's most comfortable to them. They like the masks, and the masks generally are better, the ones they have at home, than the ones we give them in the hospital. And obviously, all surgical patients are usually pre-tested for sleep apnea by getting the stop bang questionnaire. And if they have any issues with the questionnaire, then they usually get evaluated. If they're considered to be a high risk and they were never pre-tested for sleep apnea, then we typically monitor their end tidal CO2 and monitor them on continuous pulse ox. And sometimes if they're having cardiovascular events, they may need to be monitored in the intensive care unit. Sleep specialists, should be called if you're having someone who's intolerant to a CPAP, if they're having persistent symptoms despite being treated, if they're having multiple sleep disorders, they could be having, central sleep apneas along with obstructive sleep apneas, or they could be having other sleep disorders that could be complicating things. You want them to see a sleep specialist. And obviously, if you don't have time to deal with it, send them to a sleep specialist. We'd be happy to see them. Sedatives obviously make sleep apnea worse. You want to, if someone has an elevated hemoglobin, it could be related to sleep apnea. If they have problems with their blood pressure, if they're it could be related to sleep apnea. If they have cardiovascular issues such as atrial fibrillation, it could be made worsened by their sleep apnea. So these are all things that you want to discuss with the patient who has these conditions, and maybe they may require a CPAP, and some of them may even require CPAP and oxygen because they may be hypoxic, especially say if they have cardiac issues. So CPAP and mandibular devices can help reduce their blood pressure and obviously help control their blood pressure better. And there's a lot of studies to show that it has an effect on their cardiovascular outcomes, although those studies are a little foggier. It may improve their ejection fraction in patients who have heart failure, and it helps control their atrial fibrillation. All right, so this is another summary slide, and that's basically my talk. If you have any questions.
All right, great. Let's open the floor for questions. If anyone has any questions, please either drop them in the chat or raise your hand. Yeah, Dr. Kikani.
All right, I think he's muted.
That was an excellent talk, Dr. Saffran. Thank you. I have lots of questions, primarily about percentage, because you see these. What percentage of patients, let's say you get a run of the mill, what percentage are you able to get in-lab studies these days versus in-house studies, home studies?
Probably less than 50%. Medicare patients and certain insurances like GHI, we don't have a problem getting into the lab. But Aetna, United, the commercial ones, we have a very tough time. And if we don't have another reason besides sleep apnea for doing this study, and if the patient doesn't have any other cardiac issues, then they're going to require us to do a home sleep study first before we put them into an in-lab study. And if the home study doesn't it gives us the information, then great. But if it doesn't, then we have to fight with them a little bit to get them into the lab.
And then primarily the home study platforms, which are the common platforms that are being used for home study? Is that ResMed or?
So ResMed was is used a lot, but the problem with ResMed, it's not really giving us any idea of the stages of sleep the patient's going through. The WatchPat is a newer technology which looks at the vascular tone and could somehow tell the stages of sleep the patient's going through without actually monitoring the brain waves. That's found to be a little bit more accurate. And there's some other new equipment that's on the horizon that hasn't all been accepted yet, such as the Ring, which also could tell the stages of sleep and tell if they're having apneic events. So there's some newer technology that's out there, but ResMed was a traditional one to look for pure respiratory events. It's just you can't tell when the patient's sleeping, as opposed to the newer stuff like the WatchPats. The WatchPats are more expensive. They're about $60 a probe, as opposed to the ResMed, which is about $10 for the nasal cannula. So it's a little bit of a price difference, but you also get reimbursed a little bit more for them also.
One last question, then I'll stop hogging. Any apps that patients, are there any apps that you're happy with in terms of recommending patients about monitoring or anything? Cell phone apps for patients?
Yeah, so the CPAP machines, actually there are apps that you download and they'll tell them they could go and get reports on themselves how they're doing with the CPAP machine. So ResMed has one, Respironics has their own also, and the patients download the app and it tells them that how many hours they slept, if they had apneic events during the night, and if there was any leaking from their mask. And the machines themselves give them smiley faces in the morning if they did well with the CPAP at nighttime. So that gives them positive reinforcement, and sometimes gives them negative reinforcement if they get a red sad face. So some patients that are doing well get red sad faces if they're getting a large leak from their mask, and they get upset and they give me a call. And I said, as long as you're not having apnea, I'm fine with it.
Thank you.
Oh, my pleasure.
Absolutely. Any other questions? I actually have one. Well, people might be thinking. So, we have access to smartwatches and Fitbits and things like that. Does that accurately monitor sleep health or not so much?
They're actually fairly good at monitoring sleep health, and there are some studies that have looked at that. The iWatches and the Samsung watches, I think it's called Active 2 or something. They do tell you the stages of sleep. They tell you how many hours you're sleeping. They could give you, actually, it's a similar technology to what the WatchPad and the Ring use. They could tell you the stages of sleep you're having, but they tell you it's REM or deep sleep, which is fairly good. So some patients come in with their data from their watches, and I look at it. It's obviously not the same quality as the medical technology that we're using, but it's pretty good for patients to get an idea how they're doing with their sleep.
Absolutely. Thank you. All right. Are there any other questions? Okay, for right now, it looks like there are no other questions. Dr. Saffran, I want to say thank you so much for joining us tonight and for this informative presentation. This will be available on YouTube for people to share or watch again. And thank you everyone for joining. Have a great night.
Thank you, you too.
Okay, take care. Bye.